Andre, are you still awake?
Of course.
So, then you are now live,
Yeah.
and I suppose that somebody else is in the cat lab, huh?
No. Unfortunately, we had to do the case already because as you know, we had here a severe thunderstorm, and the satellites broke down, and therefore a patient couldn't wait, had back pain, and wanted us to finish the case. And as I know, it's also session nearly over. So if you want, I can show you
Yes,
briefly,
yes, you can.
quickly that case. Is
You
okay?
have nearly 10
Fine.
minutes time to show us the case.
Okay.
So,
Okay. I'd like to start with the slides, maybe. So
yes,
if you can see the slides
yeah, we
next.
can see the
So
slide.
this, not too old gentleman with severe walking pain left, ABI, as you can see here, 0.5. And there was an recognition attempt already done in another hospital. And the next slide shows you this SFA total occlusion, and on the right side you can see here how the wire passed down, but couldn't re-enter. Actually, they also perforated. There was quite some blood outside here of the vessel in the thigh. So they stopped and sent the patient here. And next slide may show you, so of course we want to go crossover through the occlusion, potentially with a go-back catheter, which we have shown already in the other present case. I use drug-coated balloons and potentially stenting if we need. Maybe we directly switch here to the angio. The angio, which you can see here. So patient said that after the intervention, but actually 2 weeks later, he had more severe pain actually than before. It aggravated. You can see here why. You can see here once here the total occlusion of the SFA, but now you can see that also the profunda artery is occluded here in the proximal part. Maybe by some thrombus, or maybe they pulled over some thrombus from the SFA into the profunda. I don't know what happened here, but clearly now you can understand how that the complaints are worse now. So let's go further down. You can see that lesion length is maybe 200 millimeter, not really calcified, actually not calcified, but also these can be difficult to open with wires and balloons. Further down, flow is okay. I briefly show you what we have done. So we went crossover. We tried to take our wire in, and we felt already in the beginning that it was actually not so easy.
Which type of guide wire you use? Which guide wire?
Command 18.
Yeah.
This is the Command 18. And you see here, I could follow with a 5 French Judkins catheter, but only for the first centimeters, not for the last ones. Here I really felt a lot of resistance, fibrosis, whatever. We tried here to get the wire back in, but you see it's going around. Looks like a very big artery. And not to dissect further down and use the Boulia technique, we decided here to go for the go-back catheter. So here you can see the go-back catheter once again in place, that 4 French device. You can see that tip here. I hope you can see also my mouse here when I indicate something here, where the needle is inside. This is the C, which indicates in which direction the needle goes. You can see here already by injection. With a regular re-entry device, you would go parallel to the artery now and try to take the needle from the side back into the artery. But this catheter gives you the ability or the possibility to really go with that crossing device through the last millimeter or a centimeter where it is obviously not possible to get the wire through, and really take the wire directly back into the artery where the artery is open again. I think this is a very nice feature and difference to the re-entry devices which we have. So here in this case, we injected some contrast and then switched directed the catheter to the other side, as you can see here with a seam. But as with other re-entry devices, you actually also with this catheter do different projections until you're happy with the position of that catheter, and then you take the needle down. Once again, you can see how big that artery is, and here again we twisted the catheter a little bit so that the C would look now to the left, and then we took the needle out. Here, in fact, it took us two attempts to take the wire in. Here it's still subintimal. We pulled the
Why
needle
you
back,
don't use
gave
the
another
road
shot.
mapping in such cases?
You can also use road mapping, of course, in this case. Here we thought that would give you a better impression if we just do it by fluoro. But as you can see, at the end it was very easy, and it really, the catheter was not parallel to the artery, but really passed the last millimeters of the occlusion directly back here into that open segment, and then you push the wire in. And it also works over an 018 wire, so you don't have to change over an 014 wire. You can use the wire which you have already in place. Yeah, thereafter we ballooned. We took several balloons. We had to pre-dilate. We thought to use the ultrascore here for scoring that lesion, but this tracks over an 035-inch wire and wouldn't pass here through the last portion here where we took the needle through. So we pre-dilated with a 5mm balloon, and then took here an ultrascore 6200 in, and let it here balloon that lesion for several minutes. We had the time here. That's the result after that. And we thought, well, 6 is okay, but maybe this artery will take also a bigger balloon. We took a 740 ultrascore balloon here. That obviously is here the appropriate size for that artery.
Without pain? Or you,
with minimal pain. At higher pressure with a 7, there was some pain, but not with a 6. So that also told us that 7 is probably the right diameter. Thereafter, we wanted to proceed with drug-coated balloons, and clearly we were not prepared for that kind of diameter. So we only have 760mm drug-coated balloons on the shelf. So we used actually 4 drug-coated balloons here to treat the whole lesion. Let me show you the result now here after that. So this is the result after that.
You have a proximal dissection.
Clearly some proximal dissection. Here you cannot really see the distal dissection, but in another angulation you can also see the distal dissection.
At the reconnection.
Yeah.
So Andrew, let me ask you this.
So proximal distal.
When you cross into the distal cap, I see that you use the go back, and here in the US we use the out back. And do you think there's always a high incidence of stenting that no matter what your balloon result is of the distal re-entry? And the next question to that part is like, what do you think about accessing distal SFA and then crossing the CTO in a retrograde manner with the chance that you may not need to stent that portion?
Yes, absolutely. So first question, I think if you use re-entry devices and you take that device parallel to the open segment where you want to re-enter, the risk that, of course, you need a stent later on is high. Well, also with this catheter, as you can see, that area where we need to go back, where we have problems, also if you go retrograde to solve this kind of problem, these are obviously difficult areas, difficult lesions, calcified, fibrotic, and this characteristic, of course, increases the risk that you need stents there. So always, if you have problems, if you need additional devices, bidirectional approach, the stenting rate is higher, also in this case. And clearly, of course, usually the retrograde approach would have been here the alternative to the go-back catheter. But, this catheter is currently a competitor to our retrograde approach, because it's so easy to use for French, but clearly at the end it will also be for us a cost issue. Going retrograde is very, very cheap, also easy, very successful. We'll see in the future whether it will take a place in our armamentarium, but definitely it's very successful and easy to use.
And did you pre-dilate before you did your DCB?
Yes, we
you do-
pre-dilated with a regular balloon to take the ultra score down. Ultra score 6, 200 scoring balloon, and 740 scoring balloon before we took drug-coated 7 millimeter diameter down.
So do you do one
Yeah.
to one, or is it okay if you do a middle? Yes.
Well, I think yes. I think you don't have to undersize your scoring balloon. I mean, it depends how semi-compliant your scoring balloons are and how semi-compliant your drug-coated balloons are. And if you still can reach the diameter of the scoring balloon, which will potentially overinflate with high pressure. If you still match that diameter, 7.5 or so, if you inflate your drug-coated balloon with high pressure, I think this is no problem.
Okay.
But with this remaining dissections, we thought to take 2 stents in, and here we decided to take superior stents in. I think with this non-calcified disease, we also could have taken others. But we thought a 7.5 millimeter diameter outer supera is very unique for SFA, and our impression is that if we take big superas in, patency is very good. So we took here a 780 distal, which was over nearly the whole length, relatively easy because of the very aggressive and thorough pre-dilation. We packed at some points.
You have some
Very
area
hard,
with
but at the
compression.
end- Yeah,
It was
yeah.
intended
So at
or
some. Well, I mean, if you feel resistance and you see the stent elongated because it's maybe a little too big for your artery, then you start packing. I think it's better to pack than to leave an elongated segment. But as you can see here, some areas are a little bit packed. Some areas potentially could have been packed better. We see over time that it evens out, and the distributional struts are more homogeneous. So therefore, I think this is no problem with packing here a little bit. And we took another supera here proximally in. This is a 740 now, which was actually also relatively easy to take in. I show you the result now. So this is here a result. Approximately a little dissection, but I think clearly not flow limiting. And otherwise, I think very nice result here also in another angulation.
I am surprised that
Yeah.
you didn't recanalize the perfunder.
Yeah, you're right. We could have done this maybe with another supera or just aspirate.
Because this vessel,
Yeah.
this vessel is extremely important for this patient. And
Sure.
maybe this is
Yeah.
just a short occlusion. Maybe you can think about
Yeah,
a
I think it.
next session.
Yeah, I think it's a more chronic embolus, more chronic thrombus. So, and by this, maybe a little difficult to take out or treat. But
Yep.
yeah,
Andre, great demonstration. Thank you again, and congratulations.
Okay. Thank
and
you.
What happened in Leipzig?
Yeah, thunderstorm, a lot of rain.
Yeah, but
Flooding.
no snow. Without snow.
No, unfortunately not. No. Yeah.
Okay.
right.
Have a great
All fine
night.
now.
Bye. Bye. See you
Okay.
tomorrow.
Thank you. Thanks.
Thank you.
Bye-bye.